Okay, good evening. We're going to begin our webinar for this evening, and I am very proud to be presenting this event tonight. And just let me get this slide going. It's not going, Annabelle. I just need to, I can't do it. It's not working. Just let me get the PowerPoint working here, and we'll just try this for a minute here. Screen share. Good evening. Yes, good evening, Emily. We see you're here. Emile. Ooh. Remote, no. Kent, give it over to Kent, yes. I can't do it. It's not doing it. You are screen sharing. Okay, we've just got a couple of little technical glitches here, and we'll just wait hopefully while some more participants join us. We'll be with you shortly. Oh, give it to me. Now. There we go. Okay, fantastic. Thank you for technical assistance. All right, good evening and welcome. My name is Catherine Norton. I'm going to be your host this evening. I am the CEO at Heal with Laser and very proud to be presenting tonight. I have got extensive healthcare experience. Over 20 years, I've worked with hundreds of practices in the area of things like practice management, patient care, business development, and in the last several years, I've been involved with MLS laser therapy, introducing that into practices as a game changer for how they run their practice. And we're going to be speaking about that tonight, exactly that. Let me tell you a little bit about the Practitioner Symposium series. We were going to hold this as a live face-to-face event in Sydney at the beginning of May. And like many of us, we had to rearrange our lives and change our plans. So we are now running this as a webinar series over the next few weeks, offering it at no charge for the foreseeable future. So the vision for our Practitioner Symposium series has been always to bring together people who are interested in laser therapy, who are practitioners, to share ideas, clinical cases, have a conversation, and really try to educate people about laser therapy and what that means in Australia, in our Australian conditions. In the coming weeks, we're going to have a few more of those people that were scheduled for the May event come and join us. We've got Lindy and Pavel Kubrick from Balance for Life in Sydney, Bronwyn Cooper from Dr. Foot Solutions in Sydney as well. And also we're going to be joined by Giacomo Granazio, who is the area export manager from MLS Laser in Italy. So we've got an exciting lineup coming up for the next few weeks, and we will be sending you information about those. So hopefully you can join a little more in the future. For tonight's presentation, we will have a Q&A session via the chat function on your Zoom connection, and that's going to be at the very end of tonight's presentation. So we look forward to hearing from you. We've already had a couple of questions come in from people. Let me just tell you a little bit about ASA Laser. ASA Laser is based in Italy, And the thing that's most impressive about ASA is that it offers a totally unique therapeutic experience with 25,000 machines all over the world, a dedicated research team constantly trying to upgrade the research backing for ASA and MLS laser. All of the protocols in the laser are based on clinical research. And there's a picture of our CEO and founder, Lucio Zaghetto, and he's been the driving force behind ASA laser. All right, the reason that MLS laser therapy is so dramatic is that it offers a way to change your business model. Most of the practices I work with are interested in trying to find new services for existing patients or find ways to attract new patients. So bringing laser therapy into how you operate can be very helpful in that it provides outstanding clinical results, increased patient satisfaction, and increased referrals. So we're going to be speaking about that in relation to podiatry this evening. I just want to say one little aside about Australia and how we're doing in the coronavirus before I introduce our speaker. I know it's been a tough time for everyone. We've all had to rethink our businesses and our practices and our lives and our family situation. And it's been very stressful for a lot of us and a big challenge. But we need to take confidence in the fact that Australia is doing very well. And you can see some of those results there. Based on our population per capita, we have 4 deaths for every 1 million people, which is a lot less than many other countries in the world. So we need to take a moment, be thankful for where we are in terms of this global pandemic. Now, I'd like to introduce Kent, and I'm happy if Kent would like to jump on board. Whoa, hang on, I just lost that. Screen sharing has dropped. Okay, Windows closed. Let me try and get the screen sharing back again. Share screen, okay. Hang on, that one. Let's go. Okay, let me just do this. View, slideshow from current slide. Okay, is that okay? All right. Finally, sorry about that, Kent. That's a dramatic beginning. We have with us Dr. Kent Hungerford, who has a bachelor's, a master's, a doctor in various aspects of podiatry, and he will explain those to you, talk about those. He's also a fellow of the Australian Academy of Podiatric Surgeons. He's a specialist podiatric surgeon and podiatrist, so he's extremely well qualified, and I feel very honoured to know him. I met Kent a few years ago when we were brought together with the mutual interest in laser therapy, and I've been out to Western Australia and heard Kent speak and see him work out there, and now he's back in the East Coast, and I'm very happy to consider him a colleague and someone I look forward to working with more in the future. In addition to Kent's extremely great academic qualifications, there's another aspect to him I think is very impressive, and that is that Kent is leading the way for the future in Australia in terms of technology and the adaptation of laser therapy into the clinical setting and looking at applications. He's extremely research-based and evidence-focused, so you'll see that come across clearly in his presentation tonight. And he also offers a changing model of patient care, which I think is something we all are thinking about, especially right now. And finally, he has the pragmatics of running a practice. So he knows what it's like in the day-to-day business of running a practice and being a practitioner. So at this point, I'm going to turn my video down and off and turn it over to Kent. I'll still be here, and I'll see you at the end of this, this presentation. So let me go ahead and do that, and I'll mute my audio. There you go, Kent. Over to you. Can't hear him.
Great, thanks, Catherine. That's fantastic. I really appreciate that intro. I'm going to just...
Oh, he can't do
So just a bit about me. Yes, I'm Kent Hungerford. I finished my Doctor of Clinical Podiatry and registered as a specialist podiatric surgeon last year, but I've been using laser therapies for about 4 or 5 years now, and just find that I wouldn't practice without them now, particularly as I move into my surgical career. I just find that they're, immeasurably a positive aspect to how I approach everything. So, a few details for myself, but really, I want you guys to walk away with an understanding of how laser therapy can help strengthen the modalities you're already using to heal your patients. As podiatrists, as physios, as health practitioners, we use quite a few different things, and laser therapy is really here to augment what we're already doing. It's to increase that healing rate and increase the rate that patients' pain decreases. And we'll talk a little bit about that further as we go through. And just, a realization that it is as good as it sounds, and it is going to be revolutionary. It could be. I'm always so surprised that we don't already have something, the take up that we should have for laser therapies. So I'm going to go over a very basic overview of how low-level laser therapy, or the proper term being photobiomodulation therapy, how it actually works. We'll go through a quick history, the mechanism for action, and the physiological changes that take place. And then what we're really all here for is the applications of the laser therapy, with a focus on the musculoskeletal conditions and current evidence. And then with that, just a few case studies of myself. As Catherine said, we are wanting to then go through and have a few question and answers. We already have had a few via email, and so I would encourage you to put a few in the chat there so that we can have a bit of a further talk at the end of the presentation. To give you a bit of grounding as to where we are within sort of the spectrum of light and lasers generally, our class 1 lasers that we can see over here, they're really safe, 1M, even up into these class 2s. These are generally what we're going to be finding with our laser pointers that you can get in the toy shop, and that your professors might be pointing at slides, or you may be doing yourself. As we start getting up into this 3R, 3B, we're starting to find some of the amount of power that we need to cause a change at a cellular level. And then as we go into the class 4, we're really starting to look at our higher power lasers, which are really going to make a difference, and at the right spectrum and dose rate are going to cause quite significant changes at a cellular level. As we go into the higher power class 4s, you're then looking at your medical grade cutting and then your industry cutting lasers, which are quite a lot higher than what we're talking about. To put you into a bit of an idea of where we are within the spectrum of light, again, we're talking about the near infrared and red light, really around sort of this area here, generally around the 620, and then going up into the infrared around that sort of 840 area as well. We're not X-rays, we're not gamma rays, we're not radio waves. Everything that we're talking about is really quite safe around this level. And to emphasize that, we're talking cold laser. It's not heat, and I need you to sort of think about that as being more like photosynthesis. So what the red light and infrared light is for our cells is like the sun is to plants. Again, to bring us back into a bit of an idea of where we're talking about, we're going from the tissue, the cells, we're going into the mitochondria with our laser therapy, going into the electron transport chain, and down into that cytochrome C oxidase. And at that level, we're affecting the ATP, adenosine triphosphate, our nitrous oxide, our reactive oxygen species, and also our nuclear factors. As a result, that's going to help gene transcription. So that's the transcription of DNA, which will affect the cytokine production and the cell survival overall. So you can imagine how this is going to be of benefit for us as we're healing, and to increase the efficiency of which this occurs. So this is for those that are very research focused. And this is what we know as of about 2-3 years ago as research-based effects that are happening at a cellular level. Because I know we don't have all night, I won't go into the exact details, but you can see that we're increasing a lot of good things, decreasing a lot of bad things. And the main thing is that it's starting really right up here in the mitochondria on that cytochrome C oxidase to have that overall effect of decreased pain, resolving inflammation, decreasing edema or swelling, and increasing that tissue repair rate, which is so critically important. Again, to have a bit of a further look at that, we do have great research on that angiogenesis and neovascularization to increase the amount of blood flow available in the area, decreasing that blood flow, increasing that nerve regeneration, increasing that cartilage production and bone formation, whilst also increasing that muscle regeneration and, quite interestingly, the muscle fiber alignment, whilst also decreasing that potential for the muscle atrophy. And collagen production is also increased. Safety is always a big thing when we start talking about lasers. People don't fully understand them or think about the old Bond movies and lasers being quite an unsafe type of concern. But there's no side effects that have been clinically reported. It's not for open eyes at higher levels into those class 4s. And we do generally wear glasses. Depending on the state that you're in, there is going to be different laws and regulations around that. New South Wales is a little bit more lax. Western Australia have a radiological council for which laser therapies and electronic devices come under. But in saying that, we're finding that there's a real good amount of research coming out looking at dry macular degeneration where the laser is pointed directly into the light, into your eye. So, you know, there's all this really exciting things that we're going to be seeing over the next years to decade as well. From a practical point of view myself, we've always worked on not on the stomach or lower back during pregnancy. And it's more just that we don't know what we're looking at. There's no specific evidence contraindicating that. And that goes similar for cancers. I think, you know, once patients are on radiotherapy or chemotherapy, there's really good evidence about decreasing some of the concerns related to that, such as oral mucositis and some of our other, you know, ulcers that are related. But also, you know, just being aware and having a chat to their care team to make sure that you're not doing something that is not unknown to their oncologist potentially. Which I've covered there a little bit too. But again, I think it's Royal Melbourne are using that as a prophylactic option in those to prevent oral mucositis of the mouth. And as I mentioned, yeah, there's a few different regulatory bodies that you need to be looking at. So to give you a bit of a background and history of how laser therapy has come about, it's not a new concept. It's coming back from 1916 where Einstein proposed the phenomenon. Going forward a little bit further, we have our first patented laser in 1960. 65, the first 100-watt CO2 laser was used in tumour therapy. And that taught us quite a lot because although it resolved the tumour at a cellular level, which was less known in that era, it actually spread it quite a lot. So, you know, it's changed how we approach different things with regards to the types and use. In 1974, we had the commercial lasers available through to 83 when the UK physios started using it for sports injury. Now we're talking 1983 that this started and we still don't have laser therapies mainstream. We have the evidence, so that's what we're going to have a bit of a look more at tonight. NASA have been using it since 98 and the US military since 99, and that's looking at nerve regeneration. As we come a little bit more into the new millennium, we're looking at spinal cord regeneration. 2006, it was laser therapies were published on the cover of the journal Nature, quite a prestigious sort of journal there with a high impact. And similar in 2010, the American Physical Therapy Association started recommending it as a standard treatment for Achilles tendinopathy. As of 2016, we've got significant literature and systematic reviews, our highest level of evidence, showing that we have that to increase muscular performance, decrease knee arthritis and pain, carpal tunnel syndrome, and increase healing rates in pressure ulcers in those with diabetes. As of 2020, we're getting 40 new studies per month, possibly more, with over 500 RCTs published, Cochrane reviews, and over 5,000 studies published overall. So there's quite a body of evidence, and I would, implore you all to have a bit of a look and see what conditions you're currently treating and how laser therapy might be able to augment that. The future, the now. So the now, like I mentioned, we're looking at pain, injury, and dysfunction of musculoskeletal system. The oral mucositis, the muscle fatigue, lymphedema, the wound healing. Neuropathic pain is a huge one for me that I treat. Orthodontics, the dentists are great researchers, and so they've just taken on board so much more, which is a real shame that sometimes we're not as research-based within the podiatric scope. Age-related macular degeneration, I mentioned. There's early research and building research on the stroke, depression, PTSD, TBI, tuberculosis, nerve regeneration, spinal cord injury, Alzheimer's, Parkinson's, heart disease, glaucoma, sperm mobility, snake bites, and the list does go on. There's more and more, and it's really great to see that we're starting to get researchers all around the world from multiple companies, universities, and governments really supporting laser therapy and the movement forward. These are a few of the devices currently available. We've got some of the MLS ones here, and this is a fantastic device that I initially saw when I was in America for some further training surgically, and just was blown away that the automation behind this to ensure that we're getting correct dose rates is fantastic. One of the smaller devices and another device as well. There's all these different options that are available. MLS is using a few different ones here, and really the dual wavelengths is what we're looking at, and making sure that we're getting that near infrared and red light at the right spectrums. And I'll let Catherine talk a little bit further on that later down the track. With a focus on the podiatric scope this evening, I wanted to talk to you, give you a bit of an idea of what I see and what I treat, but also broadly what we're looking at here. And so you can see on the screen that, yes, tendinopathies, muscle concerns, definitely going to be helped significantly. Neuropathic pain, I see a lot of patients with complex regional pain syndrome and sympathetic nervous disorders. They're going to be really benefited by this. Peripheral neuropathies, arthritis, tight musculature, and that goes with compartment syndrome as well, being such a phenomenal it treats compartment syndrome so well when it's not really a mainstream thing. And I have had patients that have been able to avoid surgery through the use of laser therapies. Again, the inflammation from arthritis and gout is really well seen. And that diabetic wound healing and surgical wound healing and edema, we're going to go into a bit further. And with that comes edema and lymphedema, and then further into our nerves conditions such as sciatica, Morton's neuroma, and nerve entrapments. And sciatica is something that I treat as a podiatrist because it's really affecting the foot. And if I'm not treating centrally at that lower back, then I'm not going to have a greater outcome for the foot and ankle as well. So we need to be holistic in our approach to our scope. But again, making sure that we're informed and knowledgeable about how that goes about and the structures that we're impacting there. I've already touched on compartment syndrome, but of course, bursitis. To start with, I wanted to go through a little bit about wound healing. For those that follow David Armstrong on Facebook, I really appreciate his heads up. I think it was on Tuesday, about this new one that's only been released this month. And so I wanted to start with that because it's really around something that I also work within, being the diabetic foot clinics and the ulcers around those two. So this study looked at 13 randomized controlled trials with 361 participants. So although it's not, a huge thousands of participants, it really is groundbreaking that we're starting to get these RCTs together that are of high quality to be able to bring into a systematic review and meta-analysis. And the meta-analysis, of the percentage size difference demonstrated a significant reduction in ulcer size in the laser therapy group compared with controls. So we're not talking just P being less than 0.05, it's less than 0.0001, showing a really significant reduction. You can see there that they're treating through, so again, with that dose rate, really important with laser therapies. And so there's a lot of research around that was disproving laser therapies initially. And so please have a look at their dose rates, which we're seeing here within the wavelength in nanometers. Our treatment dose basically with 3 to 6 joules per centimeter squared, and the irradiation for 30 to 80 seconds, 3 times weekly for a month in this case is what they delivered to patients with diabetic foot ulcers. Again, every device is going to be slightly different, but having a really close look at this dose rate is really important to ensure that the research is appropriately undertaken and afterwards reviewed. Further looking at tissue repair, so laser therapy had a biostimulating effect at 72 hours with an increase in reticular activity, better organization and distribution of the cytoskeleton in the cytoplasm. So this is increased brain and cell function in those that are requiring tissue repair. And it was found to be more effective in increasing the expression of the vascular endothelial growth factor gene and reducing the transcripts of the interleukin-6 gene. So this is increased blood flow via angiogenesis and decreased inflammation. At a cellular level, this is exactly what we want, whether it's a wound, a tendon, a brain injury, it doesn't matter. This is showing that we are having that increased healing rate, irrespective of the tissue that needs repairing. Further, there was this other study undertaken looking at different wavelengths. The different wavelengths were there to sort of see what was going to be most effective. With one of those, we found that there was a reduction in ulcer size versus placebo, and complete healing was found in 47% versus the placebo of 11%, obviously statistically significant. At that 3 months, however, is where it gets more interesting, showing that you were 3.5 times more likely to have healed if you're in the intervention group from the laser therapy. And so this is where we start going, okay, why isn't this being used more broadly within our diabetic foot clinics, within our post-surgical environments? And the answer's lost on me a little bit. And I hope when we start to see the new wound guidelines coming through, international wound guidelines, we start to see a mention of laser therapy within those as well. And then more broadly across guidelines into the physical therapies and musculoskeletal conditions too. So this is just an example of what we're looking at. There is a lot of literature on the lasers around the scar tissues as well. Again, that's going to depend more on that dose rate further there too. Nerve regeneration is a newer area. It is still looking at, and I'm not going to say it does wonders, the laser therapy, but we are starting to see the different things that are happening at a cellular level. And for my patients, I definitely say, yeah, let's see how this goes. If there's something we can put into place or something that we can use at home to augment what we're doing, then it's definitely a really positive way to go. Patients are finding not only just for the nerves, but also decreasing that pressure through removing some of the edema there. So in 2018, we had this systematic review, which has shown to accelerate the process of nerve regeneration by increasing the number of myelinated fibers, and they had a better lamellar organization of the myelin sheath in doing so. So going through these improvements, because I thought this was just really fantastic research. So we're finding greater physiological function, immunoreactivity, functionality rate, inflammation, decreasing of pain, the facilitation of neural regeneration, the release of growth factors to further accelerate that, and an increased vascular network and collagen. again, you can imagine this at a cellular level, you know, all happening at once. And what sort of patient doesn't want to have this type of option if it is available for them? And so a big part of what I do is educating my patients around its ability to do it. And it's less of a sell and more of an education in that aspect. Something we see a lot more of, heel plane, plantar fasciopathy, plantar fasciitis. I'll pull in the tarsal tunnel, although not necessarily related exactly to this research, but it is something we see quite a lot within the foot and podiatry realm. This was a randomized controlled trial, and we had a question earlier today via email, and I was already covering it, and I'm going to cover it a little bit more in depth. So that for that person that had sent in the email, around whether we actually have a decrease in pain along with a decreased thickness of the plantar fascia. So we'll cover that in a second. This one was only looking at 49 participants, but found through undertaking laser therapy with a full-length silicone inner sole exercise program for all patients. So our standard practice, I would suggest. The intervention group received a type of laser therapy for 10 total sessions over about 3 to 4 weeks. Outcome measures are really important when we start looking at research. And so the AOFAS functional test, 12-minute walking test, and visual analog scale 1 to 10 during activity pain-wise. What these results found was that within the laser intervention group, there was a greater degree of pain relief at 3 months. The AOFAS was significantly better in both groups at 3 weeks and only in the intervention group at 3 months. So we're finding that sustained relief of pain. And 2 items, walking distance and walking surface, were statistically improved at that 3 months further. And there was no significant change at 3 months detected in the control group. Again, because we like to be a little bit visual at times, we can see that our laser group decreasing pain, so visual analog scale time across the bottom, our baseline, our 3 weeks and our 3 months, we're finding that there is a statistical significance within that decreased pain. We're also finding, and off the top of my head slightly here, was that there was about a 0.9 millimeter decrease on average in those that were not in the intervention group. And for those that were in the intervention group, there was a 1.6 millimeter decrease in the plantar fascial thickness as well. So for that question, yes, pain decrease is the same with a decrease within the plantar fascial thickness as well. When we move into tendinopathies, something else we see a lot of, there's a lot of research on the Achilles tendon, but a tendon's a tendon's a tendon. And so whether you want to move that between an Achilles tendon, one of our extensor digitorums, all right through into our peroneals, tib ant, tib post, you know, a tendon is what I'd sort of suggest to you. And within our Achilles tendinopathy, being something that's quite common and something that's easily able to be diagnosed, distinguished, and then treated, we're finding that within eccentric strengthening programs undertaken under supervision 4 out of 7 days for 8 weeks, and then laser for that twice weekly for the first 4, there was quite a significant difference. Looking at those outcomes again, pain during activity, crepitation during palpation, morning stiffness severity, and ankle dorsiflexion active range of motion. So again, a nice diagram here showing on the bottom here is our laser intervention group. And the intervention group did exhibit a similar result at 4 weeks as the control group at 12 weeks. So we're really speeding up that recovery so that our patients can get back to their activity, normal life as soon as they can. All other outcomes were significant, being less than 0.01. Further photobiomodulation with low-level laser therapy for treating Achilles tendinopathy. The certainty of evidence was low to very low, and the results are insufficient to support the routine use of laser therapy for Achilles tendinopathy. Although this indicates that some studies are exhibiting great results, we need large populations with stronger research methodology. And so I call on you all to start, doing our AOFAS and our other outcome measures to be able to get some of that research there. Because although this systematic review and meta-analysis went through quite a few different studies, and some of them were found to be quite strong, some of them quite weak, we need to have those stronger studies to be able to push this out, and having those laser studies done at the right dose rate to ensure that they have a good outcome as far as that goes too. So although some of the research is in its infancy, just wanted to highlight that maybe, yes, have a bit of a look at these systematic reviews, but also realize that, yes, we're still breaking ground and we're trying to figure out exactly what the right dose rate is. And I feel in the next few years that we're going to get there. A few different other studies around the comparison of effects on laser therapy. And these ones really are, for your own sort of ideas afterwards. Please come back through, have a bit of a look at these, because there's some amazing ones here that I've just put up a few of that I found quite interesting, of places that we may see laser go into the future. So that laser therapy and low intensity pulsed ultrasound, for fracture healing, systematic review around that, the muscle tissue performance fatigue and repair benefit by the power of light. With that as well, there was a great one on foosball, which was actually taking bloods before, during and post game, which just found significant differences between the laser intervention group and players that had only had their standard recovery as well as lead up and warm up as well. And then we start looking at some of the other things around, our Staph aureus, infected surgical wounds in diabetic rats, and looking at a bit about, how that could potentially be something that we can look at to reduce infection as well. So how do we treat? Again, we've had a bit of a look at what the potentials are. We've had a look at the pathophysiological side. You now know a bit about the research. So how do we actually treat this? And there's a few different, obviously, machines that do that. But really, I wanted to give you a bit of an idea, because for laser therapies, red light, infrared light, it is still a light. And so it needs to be directly onto the skin there. It can be moved around, it can be timed. It just really depends on the device that you're looking at. But for us, what are we seeing? For myself, what I'm seeing, particularly surgically, is Morton's neuromas a lot. So here I've got a case of a 45-year-old female with 8 out of 10 pain. Previous orthotics were ineffective, and she was treated with laser therapy at the intermetatarsal space, the L4-S1 of the lower back for analgesia, and also treated within the popliteal fossa and tarsal tunnel. Now, you may ask why I'm treating at the popliteal fossa and the tarsal tunnel. Really, it's to increase that blood flow down, but also accelerate the potential for the lymphatic system to drain the lower leg and foot too. And so we then have to start thinking a bit more broadly again, where we look at our lymphatics distribution and seeing, okay, if I'm treating through to these areas, what effect am I going to have at what level as well? For me, my device, I treat twice weekly for 3 weeks. And in this case, there was a significant reduction immediately following initial treatment to 2 out of 10. But also with further modification of the current orthotics and a 3-week course of laser therapy, she now no longer experiences pain. So that's a really good outcome for any patient. Now, it doesn't always happen that way, but this is something that we can introduce before we start looking at a surgical option as well. Patient of plantar fasciopathy, 57-year-old male, slightly increased BMI, having 7 out of 10 pain, is undertaking stretching, inner sole modifications, has an ortho sleeve compression or plantar fascial support, which was provided on the initial day, and treated twice weekly, only for 2 weeks, because the patient felt that they were in a comfortable position and didn't need to come back. Significant reduction initially to 4 out of 10. Okay, that's pretty good. I'm usually happy if someone feels a difference on the first day. Not always will you find that. And even if you do 3 weeks, not always will they have a difference. For this patient, it was significant not only because of the decrease in pain, but because they were able to regain a normal gait motion and were no longer limping. And the orthoses are then complemented for that longer term prevention as well. When we look into hallux valgus, bunion pain, 35-year-old female, unwilling to look at surgical options currently. A stretching and strengthening program we'll put in place. Inner sole modification, I use a lot of felt myself to the medial longitudinal arch, trying to increase that efficiency of the windlass mechanism. And we treated twice weekly for 3 weeks. Reduction immediately following treatment with resolving pain over that further 3 weeks. Now she's only experiencing minimal pain, but for her, it means that she keeps her quality of life, and being not ready yet for surgery, that she can avoid that surgery at this stage. And that's someone that we can just keep checking in over time, making sure the orthotics are still working for her. And for some of my patients, they'll come in, every 6 weeks, when you may do general care, just to have a bit of a top up as such. Make sure that there's nothing happening there and we can remove some of that edema. Peripheral neuropathy is a really interesting one. I've had some huge wins and some that I just sort of scratch my head. I'm not ready to say with nerves that, yep, we're good to go with laser therapy. But I think for patients, what I look at is something that they can have an intensive through myself and then start looking at different devices that they may be able to use from home. Nerves are very slow to repair and heal. And so we need to be looking at that in a bit more depth. When we start looking at our other contributions, if we're not looking at our B6, B12, our diabetes contribution, our alcoholism, then we're doing them a disservice. So please, make sure that you are sending back to the GP for a nerve panel, get nerve conduction tests. If it's really idiopathic or, maybe something to do with entrapment after viewing on X-rays, CT, MRI, then you've got a really good idea and a case for undertaking laser therapy. It's just using your clinical judgment to ensure that's appropriate. In this case, she was a lady with peripheral neuropathy and paresthesias, mainly burning sensations, occasional numbness, and tingling and shooting pain. This was a patient that sort of struck me as not fitting the typical case of a diabetes or nutrient deficiency. And so the experienced pain was really through that dorsal midfoot with suspected dorsal cutaneous nerve entrapments from the mid-tarsal joint osteophytes. With X-ray confirming that after the visit, we're able to continue with a laser therapy plan. Not quite as long as what I'd hoped, because by the 3rd visit, she had discontinued treatment after complete resolution. So, this is the type of effect that we're able to potentially have. For myself, post-operative healing is just pivotal. If I can decrease someone's time to full healing and their discomfort along that journey, then I feel that I'm going to be in a better position to prevent any poor outcomes and concerns. And so now that I know so much about laser therapies, I feel that it's a disservice that I don't offer this type of treatment to my patients to augment their surgical care. In this case, a 67-year-old female undertook this during her perioperative period of surgery. Surgery went well, however, there was a bit of increased edema, possibly due to higher levels of activity in the first week. Patient was provided ongoing laser therapy in clinic for 3 weeks. The edema reduced, and you can say, okay, was that normal reduction because she started taking it slow? And otherwise, she found minimal to no pain experience. Patient back to normal walking shoes at 8 weeks if no surgery had been undertaken. But really around the laser therapy with surgery, now what I do is provide devices to them to be able to use in the weeks leading up and the weeks following surgery. So we're really having that concentrated impact there. So with a bit more depth here, something that I do personally 2 weeks leading up to the surgery around their foot and concern, 2 weeks after surgery around their dressings and at the popliteal fossa, again to reduce that inflammation. And then from sutures out at about week 2 to 3 over the incision and the popliteal fossa. And it's really incredible the reduction in pain that this can have there. It is something that I want to provide research on, because at the moment I am self-admitting. It's all very subjective, anecdotal, and case studies here. So please take it with a, with what it is, and make sure that, see how you go. Have a look at the literature and then add to it as well. For me, my patients get less pain, less edema and swelling, less complications. And so happy patient, happy surgeon. This was a good one by Catherine. Catherine really suggested, okay, tell me how laser therapy is benefit and how it's unique for a podiatrist. And it sort of had me scratching my head for a little while, but I think we are uniquely placed to be able to offer that very precise yet broad scope of treatment. We're in a position to educate our patients in ways that some professions are not. Generally, we have that little bit longer with the patients. We have that close relationship. That means that we can really ensure that our patients are responding to treatment and experiencing the best treatment plan possible. Our goal is to get that patient to pain-free, functional activity. And so if we can speed that up and further strengthen our current interventions and decrease that recovery process, decrease that pain, then I think it's something that we all need to look at, consider, and see whether it's something that that we can really use. Now, I'm really proud to be a podiatrist and a podiatric surgeon. As a podiatrist, we own the foot and ankle. It's our area, and within that scope, depending on our interests, we can really push further into that. For those that have joined us that may be doctors, physios, within other fields and other health practitioners, you can really see how this would be able to work to help augment what you're already doing with those patients too. And I know that there's a lot of GPs out there that undertake this treatment within their clinics as part of the modalities that they use to reduce that reliance on opioids such as codeine. And at this stage, I'm going to hand back over to Catherine just to go through a little bit on MLS, and then we'll take a few of those questions as well. I've been seeing them rolling in, and so it's really good to see what we can answer for those there. So thanks, Catherine.
Great, fantastic, Ken. Thank you so much for that. I know that was such a lot of information that you went through in a short amount of time. And in a lot of ways, once you start talking about laser therapy, it really is the tip of the iceberg, isn't it?
Yeah, that's it. It opens up so many avenues that we can start looking at.
Absolutely. And I like those last comments about the applications beyond podiatry. And there's a slide here that just shows the very broad range of areas where laser therapy can help. And just out of interest, ASA Laser has developed a very latest laser that is designed specifically for neuropathic pain and for nerve pain. And it's actually a 7-diode laser with the latest technology, fiber optic technology. So it's trying to advance treating some of those really difficult kind of chronic pain conditions, and some of the pain that you talked about that is really challenging for people. All right, so just as Kent, I can't do the slide. Can you just put it on to the next one for me, please? Okay, there we go. All right. Maybe the last, oh, wait on. Okay, from the, just let me just do this from, okay, from, no, wait on. I'll just go down the bottom here and get to these last couple of slides. Thank you. Slideshow from the current slide. Okay, so that's that one. Just interesting, this is a practice in Costa Rica, if you can believe it, on the right-hand side, where they have embraced all of the face shields and the protection that people are trying to bring into their practices at this time. So certainly it is changing the way people treat as well. So, all right, just in wrapping up a little bit before we take questions, just to let you know, we have got some great resources for you. AMPA, the Australian Medical Photobiomodulation Association, is extremely helpful in providing terrific regular education events. They provide laser safety courses. They've got a lot of affiliations with universities, research, as well as practitioners. So I'm hoping we can, you can find out more about AMPA. There's their website there, and feel free to get in touch with them and become part of this laser community, which is really, really important, as Kent said, here in Australia. A couple of emails there for us. Feel free to contact either of us personally. And also, Kent has a YouTube channel, which you should all subscribe to. He's got some different applications. Is that right, Kent?
Yeah, I'm getting there slowly. So yeah,
Well, we can help.
People.
We can help you build it. So, but he's put on different applications and different treatments. So that is certainly beneficial for the clinician. And all right, so now we've got, before we switch to our question and answer, we will be sending you a follow-up link to the presentation tonight, which Kent has generously agreed to share with everyone. We'll request some feedback about this webinar to help us improve, seeing as it's our first one, and also ideas for future topics, as well as information about the next speakers that are joining us. Now I'm going to just switch to the stop the sharing mode, and now we can go into various chats. And Kent, you want to just start the ball rolling here?
Yeah, that sounds really good. I'm just going to make it a bit easier for me. There we go. So we've got a question around the Achilles tendinopathy papers. Were they insertional or more at the proximal part of the tendon? Some of them are mid-portional Achilles tendinopathy, and some of them are insertional. I think the greater level of evidence is really around that mid-portion. But again, yeah, have a bit of a look through and really see what the distinguishing points are there. Giving you a bit further information on one of the ones that I remember that I was looking at and did a fair bit of research around. There was a little bit there, rather than necessarily getting rid of the scar tissue within the tendon, it actually strengthened around that scar tissue and increased the fibre alignment. And it was really quite interesting how they were able to gain that idea, but also where they were looking for that too. And it really showed, you know, necessarily, even if there is a traumatic injury there, yes, there may be scar tissue, but the strengthening around and fibre alignment to increase that even past the normal post-injury was quite fascinating.
There's a lot of questions there, Kent. Hey,
no, we're just going to slowly get through it. So please keep them coming. It's great to see the interest and intrigue. I think I've got, you know, a few people thinking here. The HAV pain was really joint related pain and potentially had a little bit to do with the Joplin's neuroma. So the question was really around where was that bunion pain? And so, yes, so there could have been impacts from the Joplin's neuroma or nerve entrapment around that first metatarsophalangeal joint. In my looking at it, there was the increased intermetatarsal angle. There was that dorsomedial osteophyte, and this patient was able to have a really good outcome from the laser therapy. Any benefit from having preoperative laser therapy? 100%. And this is something that I really want to look at, contrasting three population groups from one treated preoperative, one treated postoperative, and one treated throughout, along with our control group. I think, you know, that's quite big research, and I'm not ready to jump into a PhD at this stage. But yeah, I implore anyone that wants to come and do it. I'm more than happy to, you know, start talking about that options and across multiple clinics potentially, because I think, you know, that's where it's at. I know anecdotally, my dad had an injury and I had him treating quite a lot beforehand in the month leading up, and he's just had no pain from day one, which his surgeon was just astonished by. As I am every time, you know, we're still not used to it. The patients, you know, will generally have pain.
There's a couple of questions there about the take-home pads. You want to just say a little bit about that?
Yeah, so take home pads. There's so many different things about at the moment. I'm just starting to use a new one at the moment. I'm not really ready to recommend it until I get a bit more feedback from it. There's quite a few different ones that you can source, but I think they're nothing in comparison to a base unit, and I do use my base unit predominantly when we're looking at treatment. So yes, watch this space, and I might be able to give a recommendation, but until I sort of start seeing the results that I'm looking for, I'm not ready to sort of say which one at this stage.
And Kent, that's the sort of information AMPA can help with, the
Yeah.
association. They've got a lot of information and intelligence on that already. So
Yeah, that's a great linking, Catherine. Yeah, and
yeah.
they might have a bit further evidence than what I've got. I don't want to just be anecdotal recommending something there.
Kent, there's a question here about adverse reactions related to laser therapy. Do you have any comments on that?
Yeah, so I briefly touched on it there. Adverse reactions related to the laser therapy. It's not something that I see too much of. However, in about 5 to 10% of patients that have got significant pain, edema, um, basically I'll find that they'll have an initial spike of pain, and then that will generally reduce in the 12 to 18 hours after that comes on. For some patients, this will be overnight, that following night after treatment. It's not something I've had in a while, but I think it is really much, I think, more laser is not necessarily good laser. And it's really hitting that good dose rate to ensure that we, don't overdo it. And my perception, evidence aside on this one, is that I feel that it's maybe increasing that blood flow down quicker than what we can take it away. And so it's really that aching, throbbing pain that I'm finding in some patients that I may overdose as such. That's the only adverse reaction I would suggest. Most patients don't have any pain during, after, and they'll wake up the next morning in less pain, is generally what I'll find.
Okay. Now we've just got a couple of minutes left, Kent. I might let you just
Great.
cast your eyes over some of those questions and just see. We certainly will follow up with answers to these questions in the email.
Yeah, so there's one here. Have I tried laser on complete plantar plate tears with a gap? And if so, what sort of results? Thanks for the question. It's not something that I've looked at from a surgical point of view. I suppose I'm a little bit tainted. A plantar plate, once ruptured, is pulled down into place if they're wanting to, surgically that is. But again, taping in an acute injury can be quite a good option there as well. So yes, the laser therapy will augment that. In a chronic option where we're already having hamartomas and concerns due to that plantar plate tear, it's not an easy thing to try and treat. So I'd see how it goes, but also start prepping the patient to say, if it's painful, this may need to lead through to a surgical option down there as well. It can be a progressive deformity due to, the plantar plate tear.
Okay, Kent, we'll just maybe one or two more questions. There's a comment here about Professor David Armstrong. It's as a reference.
Yeah.
Is that someone you would recommend?
David Armstrong being a DPM and very well-known podiatrist in America that treats a lot of diabetic foot ulcers. I'm not familiar whether he uses laser therapies within his clinic at the moment, which is what the question's around. I know there's a lot of podiatrists that are using laser therapies in their clinics in America, as well as locally and in the United Kingdom. I'm just not sure on Professor Armstrong whether he's to what level he's using laser therapies. Having seen the new article from his Facebook page, I would suggest that he's starting to look into it more now that we've got the evidence supporting that at a greater strength there too.
Okay, just a couple of quick ones. Kent, what about chemo-induced peripheral neuropathy? Any applications there?
Yeah, nice one. It's a tricky one. Chemo-induced peripheral neuropathy. It's not something I've seen too much of myself, to be honest. I'd have to throw you back towards the evidence. It's not something that I'm familiar with. Catherine, is it something that you've looked at all?
I think we'd have to do a bit of homework on that one, Kent.
Yeah,
And just
that
get that,
one, it's not as common that I'm seeing through my clinic, unfortunately.
this one, and we'll make this one the last one, Kent. Is there a
Yeah,
particular protocol for the treatment of conditions, or is it based on tolerance of the patient?
Always a particular protocol, always, depending on what you're looking at and what you're trying to undertake, whether that's pain relief or tissue repair, healing and decreased edema. It's really important that you get a good feel and understanding of what you're looking at. And there's a lot of resources depending on, you know, the MLS laser or other lasers that you really need to get an idea and comfortable around treating that. It is a learning process. It's a learning process that doesn't have any adverse outcomes, but it's something that I'm still trying to perfect myself to get even better and better results for my patients. So yeah, absolutely. You know, with different dose rates, you know, that can be whether it's looking at, you know, 30 seconds or a minute, 90 seconds, and making sure that it's really that energy per centimetre squared that we're putting in there, which is really important.
Okay, that is a really key factor. All right, then, that's our hour up. Kent, thank you very much for your time tonight. Thanks everyone for all your questions. They've just been terrific. Everyone's been very engaged and also tolerant for our little hiccups at the beginning of the webinar. But really, we look forward to bringing you more of these informational sessions, and we'll update you with the follow-up email in the next few days. Everyone have a nice rest of the week, and thank you so much for joining us.
Great. Thanks, everyone. Thanks, Catherine.
Okay, thanks, Kent. Bye. Bye-bye.